Okay, now we'll enter into the second part, that is the management of the oroantral fistula. It can be managed by means of the surgical management as well as medical management. Medical management is followed by the prescription of analgesics, painkillers, antibiotics, nasal decongestions. Now we'll enter into the surgical management. The surgical preparation, which should be treated by antibiotics and nasal decongestion, enlarging and excision of the fistulous tract if it is small and not allowing proper drainage, daily irrigation of sinus with warm, sterile, saline solution. If the oroantral communication is more than 4 mm, it is done by simple reduction of the buccal and palatal socket walls and undermining the wound margins to allow light approximation of the buccal and palatal soft tissue flap to close the defect without tension. It could be supported with small palatal relaxing incision. Protective acrylic splint could be used to provide a barrier to the entry of food particles. The various flap techniques. Now we look into the various flap techniques. There are three. The types of flap are local flap, distant flap, and followed by the grafting or the hard tissue closure. The local flaps. The local flap, there are three types: the buccal flap technique, palatal flap technique, buccal, and the palatal flap. Buccal flap technique. The buccal flap techniques are MAK-sih-LAYR buccal sliding flap, Reherman buccal advancement flap, buccal transposition flap. The palatal flap techniques are the palatal transposition flap, palatal submucosal flap, palatal island flap, palatal submucosal island flap, hinged or inversion flap. The buccal and palatal flap are bipedical, otherwise known as a bridge flap. Now we look into the distant flap. The distant flaps are tongue flap, buccal pad of fat flap, buccinator myomucosal island flap, temporalis myofacial flap. Grafting or hard tissue closure. The indications are: if the presence of bony defect is greater than 5 mm in diameter, failure of conservative soft tissue closure, need for reconstruction of alveolar ridge before processes. Types: general types of bone graft and other techniques. The general type of bone graft are autograft, allograft, xenograft, alloplast with or without the use of guided regeneration. Other techniques are maxillary third molar transplantation in the place of extracted first molar. Buccal flap technique. The buccal flap. Now we look at the buccal flap. After the administration of LA, elevate the buccal flap. The base should be broad with adequate width to cover the communication, which is a basic rule for placing an incision and releasing the flap. The flap must be free of tension. Repositioning of the flap across the extraction site. The flap should be sutured back to its position. Now you can see in the buccal advancements flap. Now look at the palatal flap technique. Now this procedure, the oroantral communication can also be closed with the help of the palatal flap. You can see the incision is placed along the palatal region where the greater palatine vessels are transmitting. A small pedicle of the flap is then incised and then it is sutured on the oroantral communication and it is sutured. The open wound is then healed with the white head varnish, which will heal spontaneously over time, which has a greater blood supply in the palatal region. Wounds present in the palatal region heals rapidly because of the rich vascular supply by means of the greater palatine arteries. Okay. Combined flap. Combined flap is nothing but the buccal and buccopalatal flap, otherwise known as a bipedical bridge flap. The indications are if an edentulous space surrounds the defect. Procedure: 2 vertical incisions are made palatally and buccally which cross over the crest of the ridge. Full thickness reflection of the flap over the defect. We can see that the combined local flap for the closure of the OROANTRAL fistula by means of the hinged buccal and palatal rotational advancement flap, the inversion flap, and the palatal rotation advancement flap. The hatched area is excised to facilitate the rotation of the palatal flap. Caldwell-Look procedure. Caldwell-Look procedure. It was discovered by Caldwell-Look. Because of the less traumatic approach, the lower rate of complications and better preservation of antral lining, functional endoscopic sinus surgery, otherwise called as a FIS, has gained popularity for last decades against Caldwell-Look procedure in treatment of chronic sinusitis of dental origin. Caldwell-Look operation. The indications are as retrieval of root or tooth from the sinus, enucleation of odontogenic cyst or mucocele from the sinus, removal of odontogenic tumor from the sinus, treatment of the acute maxillofacial resistant to medical therapy or showing evidence of extending beyond the sinus, treatment of chronic sinusitis, management of oroantral fistula, repair of fractures of the antrum or zygoma. The complications of the Caldwell-Look procedure are cheek edema, otherwise called as ecchymosis, infraorbital nerve dysesthesia, epiphora, oroantral fistula. Now we look into the advances in the management of the maxillary sinus disease. FIS. FIS is otherwise called as the functional endoscopic sinus surgery. Functional endoscopic sinus surgery is a non-invasive or minimally invasive surgical procedure that discloses the sinus air cells and sinus ostia by having an endoscope. It restores the paranasal sinus function by re-establishing the physiologic pattern of ventilation and mucociliary clearance. The term FIS or functional endoscopic sinus surgery was coined by Kennedy in the year 1985. The father of the FIS is Professor Messer Klinger. Hirschman first described the use of primitive endoscope to examine the maxillary sinus through an oroantral fistula. What are the indications of the FIS? As we have already discussed, the chronic rhinosinusitis, unresponsive to the medical treatment, recurrent active sinusitis, sinonasal polyposis, mucocele, non-invasive fungal ball, invasive fungal rhinosinusitis, CSF rhinorrhea, and anterior meningoencephalocele, sinonasal tumor, severe exophthalmos, nasolacrimal duct obstruction. The functional aspects of the FIS are preserving the normal structure, removing only the obstruction, preserving the mucosa, restoration of the function, as it is this shows that the functional endoscopic sinus surgery is a conservative approach. The advantage over open sinus procedure is that it is safe, minimally invasive, no cuts. It doesn't disturb the healthy tissue, only the tissue which is pathologic are removed. It is performed in less time with better management. No visible signs that surgery has been performed. Quick recovery. This gives me, I once again thank my professors to give this wonderful to my staff team for giving me this opportunity to present in front of you, and a special thanks to my dear students who have sit patiently and listen to this wonderful topic. Thank you.